it is a more, functional, okay, alternative to be scrubbing for more than 1 hour the floors. The nurse approaches the client to have him going to eat. What is the best nurse statement? This is a way of how the therapeutic interaction with that. And then you have the following option. You can stop washing the floors because housekeeping can take care of it. So it is logical, but it's not helping the client. The client cannot depend because it has an irrational fear to the dirt. And the only way of relieving the anxiety produced by this fear is to he or herself clean immediately the floor. And this clean the floor relieve the anxiety. And if the cleaning is done by another person, is not to produce the satisfaction or the relief of the anxiety that produces the compulsion in the client. So this option translate that the nurse doesn't understand what is OCD. Yeah, the need or the compulsion or the action, in this case, cleaning, to relieve the anxiety. So you rule out this option because definitively it's not therapeutic. The other option says, I will be back. Okay, I'm coming back in 5 minutes. 5 minutes is a time in comparison with 1 hour or more is a shorter time. And then is to take you for lunch. And the client is going to eat. The client knows they have to eat. The client probably is hungry. Yeah. So it could be a solution. Why? Because you are allowing the clients to continue scrubbing the floor. You are not prohibiting, you are not limiting the client from scrubbing the floor. The client can continue, if he or she wants, scrubbing the floor. The only thing need to do that very fast because in 5 minutes the nurse is coming back and they have to go to lunch. The client is not stupid. The client know that needs to go to lunch, is hungry. Yeah. And what he's going to do is a very fast end of the scrubbing. Okay. So it's going to scrub very fast, very intensely in these 5 minutes because they are limiting the time dedicated to the compulsion. But the compulsion is not prohibited. Option C says you have to stop cleaning the room. So this is no good. Why is no good? Because they are prohibiting the compulsion, and this is going to produce a panic attack. This not going to be nice, and the client is not going to be happy. So this option is not the desired. And the last say you can continue scrubbing the floor after you finish your lunch. This is the same. This is say you are not going to continue scrubbing now. You need to postpone this need, this urge, this urgency that you have to clean. You need to postpone that to after you have lunch. This is not acceptable. So the only option here that allows the clients to continue with the compulsion but limiting the time is option B. So option B is the right answer of this question. So I hope that this question consolidates the the teaching that I gave you how to deal with compulsions in patients with OCD. That is, you cannot block, you cannot prohibit, you cannot hinder, you cannot stop the compulsion, but you can limit the time dedicated to that because those clients are not crazy. Those clients are smart. They understand. Yeah, very good. So this is a good question to understand the management of the compulsion of OCD, which is a common question in English. Personality disorders are also tested in English. There are many personality disorders, but the 4 personality disorders that are being and are mentioned in the English text plan is the antisocial personality disorder, the borderline personality disorder, the histrionic personality disorder, and the narcissistic personality disorder. All 4 have been present in English. And you need to have an idea of them. Why you need to have an idea of them? Because they can be hospitalized because of the problem. You can have an antisocial personality disorder that is hospitalized because fought with another prisoner in jail and has I don't know, a wound, or you can have a borderline personality disorder has an appendicitis, or have a narcissistic that is admitted to a surgery, you know and you need to deal with those personalities, and you need to know that those personalities exist, and those personalities are need to be accepted and need to be managed in the proper way. Antisocial personality disorder means that this client is a threat to the society. I remember when we studied, I'm talking about the last century, uh, many years ago, my first exposition to mental health, I had a psychiatric professor that said the antisocial personality disorder should be in jail. Okay, this is a client, the personality that should be all time in jail, and you leave those people in jail. Okay, maybe it was exaggerated, but it made me understand what is antisocial personality disorder. Antisocial personality disorder is a person that has a severe trastorn, defect of the personality, where the how you go the super personality that control your impulses. That these are these these your when you have in the comics people, you have somebody that is talking in one shoulder with a devil, and the other shoulder an angel, and they are balancing each other, and they are advising the person, and the person take the decisions. Okay, this person, the angel left. Okay, the angel fell in the way, and only have the devil in one shoulder. So it's a person that is definitively having a total uh, disregard or ignores, okay, the feelings of others, the right of others, and a person that have no regrets, have no feelings of of yes, regrets about their behavior, and they don't care. They don't have anxiety. Okay, they don't have nothing to make them anxious, because they don't care about that. The only that they need is the satisfaction of their needs or their desires. For that reason, they are very manipulative, very manipulative to obtain their, and frequently they are related with delinquency. Okay, it is a reality in antisocial personality disorders. It's something that is integrated, is not well understood why, but it's integrated in the personality since very early. So you can see in the childhood of these people problems like disorders in behavior, conduct disorders in childhood. Yeah, and then you can have children that have a disregard of the rules, and you see that they have animal cruelty. Children are not cruel with animals, by the contrary. But then you see animal cruelty, and then since early time you see in them truancy, delinquency, substance abuse, runaways, etc. Very severe problems. These intermittent passive aggressive disorder that I mentioned here is not really related with antisocial personality disorder, but it's a common personality disorder that is parallel but associated with this is are people that tends to be very passive in dealing with the stress of the life, but then suddenly explode and becomes very aggressive. Okay, so they have a continued hostility, against the society, the environment, and they accumulate passively anger, anger over anger, until there is a moment that have explosive outbursts of violence and anger. And then is when you have situation like, for example, road rage. Have you seen in the news? Okay, the frequency of the road rage that we are seeing nowadays, domestic abuse, throwing or breaking objects in tempered plants have a very high risk of homicide and also homicide and suicide. Okay, so it's not exactly the definition of antisocial personality disorder, but I prefer to study together because reminds me the problems of the antisocial personality disorder that frequently is associated with delinquency. Okay, no suicide. They don't commit suicide, but yes, delinquency. I mentioned it because those are being the conduct disorders in childhood, and the intermittent passive aggressive disorder, and the antisocial personality disorder have been all them in English. The questions are very simple. Only if you know that this condition exists. Only if you can recognize those conditions. If you have a child that is very rebel, there is no way of introduce disciplines in the process that Erickson described, like initiative versus guilt, that start in the preschool age, where we learn that if our initiative is not allowed, we are going to have guilt of the punishment. And when you notice that this is not working in children, and they have some characteristics like very cruel with the pets, with the animals, very extremely cruel. Okay, and then they have having problems of stealing, abusing, etc. Uh, this is the conduct disorder in childhood, as this is the way that it's called, that can be associated with later with antisocial personality disorder. And this intermittent passive aggressive. You hold, and then boom, you explode. Yeah, passive, 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 boom, and you explode, and you explode. Very exaggerated. Yes, this is the intermittent. It's not continuous. It's intermittent. While you are passive, 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 you are not exploding, and then boom, you explode. Okay, intermittent passive aggressive disorder. I just mentioned that because has been in people that have already taken the NCLEX had this stuff. What is that? So they describe the scenario, and then you need to recognize that it is a case of these conditions, and you need to understand that are people to be careful with them because are very difficult to manage. Um, in these situations, antisocial personality disorders and this situation, you need to know that confrontation, and you know what is confront, no? You know what is going to confront. Confrontation can be therapeutic. You can help, you can be therapeutic if you do confrontation with this type of behavior. For example, a question that say you have an antisocial personality disorder hospitalized, and this antisocial personality disorder is has a morbid obesity, and at the time of the lunch, when they are all the clients are having lunch in a common place, this person is stealing food from the other client. What you need to do, you confront the client. You say, don't do that. You cannot do that. So this is the right intervention. You confront the client. You understand? You have an antisocial personality disorder and want to touch you in inappropriate way. What you do, you confront the person. Yeah. The same at this other situation when they are a behavior that is unacceptable in under your supervision, under your management, uh, you confront the client. So confrontation with those clients is correct, is therapeutic. Okay. Remember that you need to always have ready for the support of the rest of the facility. No, you have a security, etc., etc. In case that your confrontation is not enough to control the misbehavior of those clients. Borderline personality disorder is a person that is so psychologically affected that they gave this name is in the border, is in the boundary of the psychosis. So it's not psychotic, it's not a psychosis, but it's such a severe alteration of the personality that the person seems to be almost crazy. There are people that are extremely unstable. Their emotions and their mood is very labile, has an intense lability. So in this moment, is laughing in 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 very extreme form, and then 15 minutes later is crying and is feeling very very sad. This is not bipolar. Bipolar don't behave this way. Okay, don't confuse bipolar. Bipolar can have extreme changes in mood along a long time, a long month. So have month in which the client is high, or can be having years or month with the clients is low. This is not. This is from now to 15 minutes. Okay, very emotional ability, are very impulsive. Okay, they act and then after that they think if they think. They tend to have low self-esteem, and they need to have attachment, a lot of dependence with other persons. And but at the same time they are very manipulative, and they have a bad habit, splitting. Splitting is that you are good or you are bad. Guys, nobody is totally good and nobody is totally bad. We are a mixture of good and bad. Yeah. And well, some people have more good than bad, and some people more bad than good, but you are a mixture. It's not usual that people are totally good or totally bad. They see the people or totally good or totally bad. And the sad, the bad stuff that in the morning you can be totally good, okay? You are the best, and then in the afternoon you are totally bad. And this is called a split. This is called split. It is something no good. For example, you are the nurse that is receiving the shift. You are coming, and then the leaving nurse, okay, presented you, uh, the clients, and she or he left. And then a client with borderline personality disorder approaches you and tells you, "Oh, I'm so happy you are today on duty because you are such a good nurse. You have such a good knowledge. You are such a good ethics. You are such a splendid nurse. So you are good, 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 good. You are the best, the best, the best, the best, the best." Yeah. And usually this person that is telling that you are so good, start talking bad, very bad about the nurse that is leaving. It's not like this nurse that is leaving now. She doesn't, or he doesn't, he's not a good nurse. He doesn't have the knowledge. He's not have the ethics. He doesn't like their profession. Or she mistreated the clients. Bad, 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 bad. You good, 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 good. She or he is bad, 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 bad. And then the clients little later comes to you, say, okay, can you please give me my Percocet, my opioid, because I have pain? And you answer, yes, yes, of course. And then you go to the medical administration records, and then you discover that the nurse that just left, okay, half an hour later or 1 hour later, they just left, already gave before leaving the Percocet. And the Percocet is every 4 hours or every 6 hours. And then you tell the client, "Oh, I'm so sorry, but I cannot give you the Percocet because I noticed here that the nurse that left already gave you 1 hour ago the dose." And then what is the reaction of the borderline personality disorder? Aren't you going to give me my Percocet? Okay, now I'm going to do something that you are going to regret. And then go to her room or his room, generally it's her, to her room, and, for example, cut the skin and start bleeding. Okay, so self-mutilation is a way of draining the frustration, okay, the frustration, or can be a way of manipulating, can be either one. They can self-mutilate, they can cut themselves, okay. It's a common behavior, because when they cut themselves they feel better, yeah, or can do that simply by manipulation, okay. So, and that's why those clients frequently have scars of self-mutilation. And those clients frequently are very impulsive, take decisions that can be risky because this decision can, for example, to commit suicide, you know, and they are very impulsive. And then they can commit suicides without thinking. It's a very unpredictable suicide. Frequently, they suffer of bulimia because this impulsivity and this emotional inability makes the clients use the food as a relief of their anxiety, their frustrations. And those are the characteristics of the borderline personality disorder. As you can understand, it's a very difficult to deal client, you know, and that's it. This splitting has been frequently mentioned in questions. The self-mutilation has been mentioned. And in general, it's a client that you need to keep an eye all time the clients and need to be very careful because it's are very manipulative. You need to be very careful dealing with those clients. Um, Histrionic is attention seeking. You can summarize this personality disorder as attention seeking. It's a person that can be nice, Many, a lot of people from the, the movies, etc., from the singers, etc., have a histrionic personality and have a lot of fans. Okay, so but it is a person that feels the necessity of calling the attention continuously. So that's why they dress and use makeup and comb, etc., to call the attention. And they behave, they talk, and they demand attention. Okay, and they can be really dramatic and be very dramatic and to call the attention. And the narcissistic is generally a person that have a wrong sensation of superiority or grandiosity. They are convinced, and there is no way of changing that. That it's very difficult to discuss with a narcissistic. It's very difficult to discuss with that. They always need to win. Okay. Uh, um, they are convinced they are superior, and the sad part of the narcissistic, at least it is a personal experience, that generally are not very smart. Narcissistic people, in my opinions, are not very smart. At least the times that I have been dealing with narcissistic people, and but they feel superior. Okay, they feel the best of everything. They are the best. They are genius. They are superior. They can solve all the problems. If uh, is very superior, and they need that everybody admire them. They don't tolerate dissent. They don't tolerate uh, critics. They need everybody admiring them. They don't show empathy. They don't show solidarity. They can use that. They can be smart using, an image of solidarity, and they can even be in a religious organization, etc. But they don't. You notice that it's not a real. It's not true, and they like to put others down. So they goes up, pushing the rest of the people down, and they make a lot of mock of the other people, okay, and tend to be very arrogant and are very difficult clients, okay. It's important in the personality disorder that you need to set limits. You cannot allow those people with those personality disorder to control you or control your chief or control other clients. You need to set limits, and avoid bargaining with those clients. Mood disorders is what we call bipolar, no? And there are different, okay, type of bipolars, okay? So we are not going to go in depth of the type of bipolar. We are going to, because we are not psychiatrists, It's important that we cannot answer questions in English as we were little psychiatrists or psychologists. We are going to face all those problems. We need to have a general idea and how to do with them. So the bipolar have different types. Some people are all times in depression. Some people are all time in mania. Some people oscillate between one or the other. The intensity changes, so the classification is very complex. This is not in our scope, and I don't recommend you wasting time in that. Remember that NCLEX is a generalist entry-level test. It's not a specialty test. Okay. Um, you can have in the question banks specialists, nurses, psychiatrists, nurses specialized in mental health, writing the question and can be a little deep. But generally, what we have been seeing in English is this very general level, entry level of question. What they are going to be very practical. What you do with a patient with depression that you suspect could be suicidal. What you do with a client with mania that is escalating into aggression and can become violent, etc., etc. Okay, the major depression is this depression that is seen in bipolar disorders that is very severe. You or me can become depressed if we lose something, somebody dies, okay, we something happened to us. But those are reactive depression that are normal, events in life. But there are people that can have depression just because functional alterations of the neurotransmitter. So those substances that make the brain work, the neurons work, are the neurotransmitter, especially the dopamine and the serotonin and the norepinephrine. Okay, they are so important for the mental or cognitive functions and the mood, okay, are altered, and then they can be depressed without nobody dying or something, etc. It's part of the disease, yeah. And the level of depression that can happen in these clients that have this alteration of the neurotransmitter can be very severe. And then you're going to see that these patients are in a negative inhibit, minus inactive, inhibited mind and physical uh, 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 functions. Mind is thinking. Okay. So how are they thinking? They think very bad. They suffer a lot. They are very sad, melancholy. They are with a very low self-esteem. They prefer to don't exist, to not existing. Um, they don't take decisions. They don't solve problems when they are in this severe depression. Whether physical, okay, they don't take care of cleanness. They don't take care of the job. They don't take care of the studies. They don't care take of nutrition. They don't take care of the family. They don't take care because uh, if you don't have the drive of the thought to act, then everything is inhibited. And this is called psychomotor, okay? Because psycho is mental, motor is the action, is to act, is to move, yeah? Psychomental inhibition, psychomotor, pardon, excuse me, inhibition, yeah? So you're going to have the clients have self-neglect in hygiene and nutrition. This is something basic in Maslow, no? Nutrition, hygiene, you know, self-care is basic in Maslow, so it is not covered. Anhedonia. This is a term that you need to learn. Normally, people enjoy pleasures. There are several pleasures in life. Okay, maybe it's chocolate for you, maybe it's alcohol, maybe it's smoking, maybe it's sex. Okay, or they are all of them. Yeah, but those are pleasures, and the normal is that you like that you enjoy when you have those pleasures. You enjoy them. Okay, in an adequate proportion. Okay, so those people. don't enjoy any of this stuff. There is anhedonia. This is a loss of enjoyment of the pleasures. This is the term. When you see the prefix a, the letter a or an, okay, you know that is absent. And hedonia is a Greek term of one of those Greek gods that you know that was the pleasure god, you know. So that's it. Psychomotor retardation in action, as I mentioned before, oversleeping is the most common. Sometimes they have periods of insomnia, especially at night, but maybe during the day, oversleeping is frequent. Um, Very low self-esteem, and because they are suffering so much and they have this so low self-esteem, the risk of suicide is so high, and we already talked about this, that suicide is an emergency, is a priority in nursing, in psychiatric nursing, and suicide is very related with depression. So everything is around suicide in those clients. A part of taking care of the basics, okay, a part of stimulating them to becomes active, uh, supervising and avoiding the suicide is the priority. Mania is all the opposite. In mania, the patient is going to be exaggerated, abnormally, inadequately, okay, happy, with very elevated mood. And then they suffer of something called grandiosity delusion. Don't confuse the grandiosity delusion with narcissism, because in narcissism there is not psychosis. The client knows what is right or wrong, and there is no psychosis. Okay, it's just a wrong self, evaluation. But in the mania, the person has delusion. You need to know that delusion, the word delusion, means crazy idea. Okay, it's a crazy idea. Okay, it's a crazy idea. Okay, so delusion, crazy idea. So if I say in this moment that I don't know, Napoleon, you say, Professor Vallin is crazy. Yes, this is a delusion. If I say in this moment that I don't know is I was born in Pluto, and I came to the Earth in a special you know a spaceship, and etc etc, you say I'm crazy. What are those ideas? Where are those ideas in my mind? In my brain. Yeah, I'm expressing this idea because my neurons, my brains are producing these crazy ideas. How we call that? Delusions. Delusions. Okay. So, for example, when a client says, "I don't take this pill," tell the nurse, "I'm not going to take this medication you are giving me because I know that you want to kill me, and this is a poison." You know that you cannot give a poison. You know that everybody that is in their capacities, in their mental capacity, know that we cannot give tablets of poison. Sometimes we want, but we cannot. Yeah, it's totally inadequate. So if a client says that to you, it's a crazy idea. It's a delusion. It's a paranoid delusion, by the way. This is a very common delusion, the paranoia, when the clients don't accept the medication from you because they think that you want to kill them, you want to harm them. So delusion is a crazy idea. Can be different type of crazy idea. But in the case of the mania, the crazy idea is grandiosity. If you don't understand what is a grandiosity delusions, okay, this picture of a cat seeing itself in the mirror, okay, is a good understanding. Is inappropriate, inadequate, illogical, uh, without sense. Okay, crazy idea. Don't confuse delusions with hallucinations. Hallucinations are different from delusions. Hallucinations are also abnormal and are seen generally in psychosis. Is when there is a distortion of the perceptions. Remember that I mentioned perception using the organs of the senses, okay? Senses, organs: vision, hearing, smell, taste, tact, okay, or touch. Yeah, uh, those are the sense organs. So when the person is experiencing a sensation that does not exist, does does not exist. It is important. Does not exist. You are seeing something that does not exist. You are hearing something that does not exist. You are smelling something that does not exist. You are touching or feeling that something is touching you that does not exist, etc. Please, this is hallucination. So when a person is hearing a voice that nobody else is hearing, it is a hallucination. If a person sees something that nobody else sees, it is a hallucination. Yeah. When somebody smells something that nobody smells, it's a hallucination. Don't confuse that with delusion. Delusion is not related with the organ of sense. Delusion is an idea that is inside the head, the brain, in the brain, no? And the person can express this idea. Okay, I'm Napoleon. Okay, I have Kool-Aid in my blood that was transfused by a crazy doctor. This is a crazy idea. This is not a hallucination. It's a crazy idea. But if I see something, if I hear something that doesn't exist, it's a hallucination. A delusion is a crazy idea, concept, idea. Yeah. And hallucination is the other. Please differentiate them because Nclex explores if you know the difference. There is another uh, abnormality condition that could
Illusion.
illusion, illusion, okay, illusion, okay, illusion, okay. Illusion is similar to the hallucination. Illusion affects the senses, okay. Illusion affects the vision, affects the hearing, affects the smell, etc. But the stimulus, yeah, the stuff exists, yes, exists, but is misinterpreted. There is a misinterpretation of the stimulus. So, for example, if I get up during the night and my wife left, I don't know, a broom, okay, a broom in the bathroom, and I entered the bathroom, sleepy, with turning on the light, and there is a broom that usually is not in the room, and I enter the bathroom, and I get scared because I think that is somebody, there is a person instead of the broom. I think that is a person that is in the bathroom, and I scream and get scared. It is an illusion. It is an illusion. It's a misinterpretation of something real. Makes sense for you? Yeah, it can happen to you. Yes, it
Yeah.
can happen. So people can have illusions, can have misinterpretation, especially when you are sleepy, when you are, under the action of substances, when you are sedated, or when it is very dark, or maybe you are, very confused, etc. No, but in mental health, also clients can have illusion. So, for example, I remember a question in English. Okay, I remember a question in English that somebody had, that the schizophrenic client is with the nurse, with the registered nurse, and the schizophrenic client hears that the ring of the door is ringing. Okay, so you know that those are close um, mental health, okay, words, and there is a door that people ring, and then somebody opens the door, okay, because they are closed environment, and then the the schizophrenic client hears the door ringing, and then the clients tell the nurse there is a horse, okay, there is a horse outside, because I heard the horse, okay, or any animal, okay, making this sound. Okay, so what is the interpretation of this experience? It is an illusion. Why? Because there is something that exists. Somebody ring, but then the mental health client made a misinterpretation, a wrong interpretation of this sound. Instead of recognizing the ring of the door, is saying that it's an animal that is producing the sound there. Okay, it is an example, okay, of illusion. Okay, illusion. When it's a bizarre, weird misinterpretation of the stimulus that exists that can perceive by the senses. Okay, so returning to the language mania, okay, the grandiosity delusion, a crazy idea of grandiosity. So generally they say they are millionaires, which is totally nonsense. They say they are going to give you a lot of gift. Don't believe it. But they want to give you the gift. They are convinced that they can give you the gift. Okay, but they cannot because they don't have money. So it's because they're crazy. Understand? Uh, they say they are royalties. Okay, they are belongs to the royalty, or they are intimate friends of the presidents, etc. So a lot of grandiosity, grandiosity. You say that all time talking about, okay, grandiosity, grandiosity, grandiosity. Okay, and this is grandiosity delusion. Their their mind is very productive. Their neurotransmitters are in too much, okay, amount and totally dysfunctional. The brain activity is rich and continuous. Of course, illogical, inappropriate, but is very productive, and it is expressed while the person is speaking. So you see that the person is continuously talking, continuously speaking. But then you know that the person is jumping very fast from one topic for another totally different. And it's because the mind is so fast, okay, is riding like a, like a rocket very fast. And this is what is called flight of ideas. So if you talk to the person and you say, how nice weather we had today, and they answer you, yes, very nice. Okay, the tsunami in Japan, okay, was very impressive. You see what had to do today's weather with the tsunami that we have the last time in Japan is because their mind very quickly, okay, they are thinking, they say, okay, this day is a very bad weather, okay, but sometimes the weather is no good. I remember that the last hurricane that came here produced very high waves in the beach, and the highest waves that have been described in the times is in the earthquakes that affects the sea, and then the waves that produce is called tsunami. And then the last tsunami that I heard of was the tsunami of Japan. So all this stuff that I so slowly, but I'm very slow thinking, okay, I mentioned happens in a fraction of seconds in their mind. And then when they speak, you say, what had to do the Japan tsunami with the fact that today we have a very nice weather? And it's because they thought about all this stuff in a very rapid fashion, and then they jumped from one topic to the next. Their minds, their ideas are flying. And you can't recognize that. They're very talkative, they're annoying, and, and they don't stop moving. They don't stop moving. They don't sit. It's a saying, no, they can sit, but it's like they cannot already be sitting. They need to be doing something, talking and doing something need to be done. They are very restless. Okay. For that reason, because they are so busy thinking, talking, and moving, they don't have time to rest. And because they are so important, they cannot stop doing that because they are very important. You understand? And they can develop sleep deprivation. they can lose a lot of weight, and they can have nutritional deficiencies because as a consequence of that. And because Maslow tells us that the priority are the physiological needs, we need to be aware that in NCLEX questions, it's very important that you are aware. You need to be aware that those clients, either depression or mania, their basic needs need to be fulfilled before going to the psychological needs and the psychological management. So feeding those clients, for example, is important. And the classical question of the finger food they can consume while they are talking, consume while they are walking, is need to be offered and need to be very dense food that provides a lot of calories and a lot of nutrients. The food that we should not eat, no, the food that we need to avoid because we are generally, overweight. The food is the food that need to be given to them, okay, to recover weight and nutrition. And then you need to promote the sleeping. Okay. For that reason, for example, they ask you which is the best room to be assigned to a mania client, the room near the nurses station. Nurses stations are noisy, always busy. And the rooms that are nearby are going to be, having noise. Okay. Or the farthest room, the room that is quietest. Okay. Remember that mania clients don't suicide. They are so important that they cannot commit suicide. Okay, they are not risk of suicide. By the contrary, a patient with depression that has high risk of committing suicide is better to put the clients near your supervision. You can keep an eye on the clients, a part of the other cares. Okay, you can have another person dedicated exclusively to the client. This is independent. But the mania client, okay, should be benefited from the farthest room to provide, okay, silence and to promote, okay, rest. Makes sense? Okay, what about the light in the room? What about the noise in the room? Decrease the stimulus, decrease stimulation. Another question that had been, if you understand what is happening in the patient with the mania, then you are going to have a practical question, what you do to calm down this crazy person. Okay, so this is the priority. But then they have another characteristic. They are like matches, okay? It is a Spanish say like a foforito. They easily escalate to aggression, to violence. They become upset very easily, and they don't tolerate opposition. How the most important person in the world, okay, how the royalty and the best friend of the president can tolerate opposition. You understand? So that's why they can easily become very upset and argumentative, okay, when something is wrong. Okay. So, for example, if they are in a common place in the facility where other clients are present, and one client decide to change the channel of the TV, this can bother the client because was not consulted. Or if they are, no, I don't know, playing, I don't know, domino, chess, whatever, yeah, and then the other person wins, is unacceptable. You understand? And they can escalate. If you are talking to another client, they are very jealous again because they are the most important person. You should be talking to them, and then they can become upset, etc., etc., etc. You know, so anticipate that the most common question about escalation to violence, escalation to physical violence, escalation to, you know, to fight, etc., is frequently a client with mania because they are easy to escalate. And then you need to recognize when they are escalating because they are talking faster than usual. They are talking louder than usual. They are they are pacing. They are moving. Okay, they are walking faster and stronger than usual. They are closing their fist. They have expression of anger. They are more restless than usual. So when you see those signs in the question, you say this client is going to explode, is going to escalate to violence very soon. And then your role is to de-escalate, to calm down this client. And you should calm down this client without restriction, without, tying the client with ropes, without placing the clients in seclusion, and without giving a shot or a tablet of a sedative to the client. Because it's the first that you need to do, the least restrictive of the clients. And then the classical question is that you turn off the TV, you turn off the radio, dim down the light. If there are other person present, you take the clients and move the clients to a place where there are no other people that can be stimulating or bothering the clients. And then you use the physical activity like walking, okay, like sweeping the floor or whatever physical activities to drain, to reduce this energy uh, of violence that is accumulated. And that's the classical question that you see in the escalation of those clients. Patient with mania, because they are the most important people, want to be more important than you. You cannot lose control of your management, of your discipline. So maybe a patient with mania can tell you, a nurse, I want a party today. Please, buy whiskey and beer and brings, music. And, that this is not allowed. So you need to set limits to the clients. You need to tell the client, no, this is not allowed in the service. I'm so sorry, okay, but this is not allowed here by the policies, etc., etc. And avoid the bargaining. Nurse, I'm behaving bad, and I know that you are upset because I'm behaving bad because I'm disturbing the other clients. Okay, if you allowed me to smoke, I will behave well. And you need to decide if you are going to accept this proposition, or you say no, you are going to behave well and you are not going to smoke, okay, because there is not allowed to smoke here, and you need to behave well, okay. So avoid bargaining and manipulations, okay. Of course, I already explained how to anticipate or diagnose escalation to agitation, how to de-escalate, how you decrease, okay, stimulation, how you take care of the basic needs, and provide gross motor activities, non-competitive. Don't put the client to play a basketball or football, because you're going to end fighting. Okay, if they are not going to win. Okay, not competitive. Okay, as an outlet of detention, and it's important that you supervise the clients in the compliance with the medication, because they don't want to take medication. Why are they been taking medication if they are not sick? By the contrary, they are the most important people in the world. Why they need to take medication? So it makes sense for them. So you need to supervise the compliance with the medication. Remember, the most common medication that I use in those clients is the lithium. Okay, among other medications, not exclusive. And this is very frequently prescribed in patients with mania. In depression, the most important is the evaluation of the suicidal risk and the prevention of the suicide. We already talked about this. But also they need help with the activity of daily living, because they have neglect of their hygiene, physical needs, etc., nutrition, etc. So you need to support the clients in those needs. Avoid, if the person is depressed, complex decision-making situations and activity that requires high concentration. Okay. If you have a person that is depressed, or a person that have cognitive limitation, you don't ask the person what you want to eat. You ask the person, do you prefer chicken or beef? It's different when somebody asks you what you want to eat. It's a very If you are depressed, I know I cannot ask you that because you know perfectly what to say. I'm talking about sick people, please. Don't make fun of me. So I'm talking a person who is depressed or a person that has, Alzheimer, for example. Don't ask a complex decision question. What you want to eat is a complex decision question. You understand? Because there are many options. What you want to dress, you know? It's better that you ask what you want, chicken or beef. Okay, you want chicken or pasta, or you want the red shirt or the blue shirt. Understand? Is an example how can be tested. These avoid complex decision making, question on situation, and provide clear indication, clear explanations. Okay, simple short sentences, not complex, and in the moment. Don't give an instruction for something that should be done many hours later, etc. you know that's the important. Stimulation is good if the patient is depressed. You're not promoting the patient to get out of the room and going to watch a movie or to listen to music or participate with other people is good. Remember that people with bipolar depression frequently don't respond to the antidepressant medications and require something called electroconvulsive therapy. You know, in the end, you are going to have a lot of stuff. Remember that electroconvulsive therapy is the use of continuous electricity passed through the brain tissue to produce something is like a resetting that is very complex. We don't need to go in depth how it improves the clients, but has been effective in clients with depression, refractory depression. But what you need to know about this therapy, that is decision of the physicians, it's not your decision, about this therapy is this: it requires all the care, the similar care as in surgery. So the clients need to give consent, sign consent. The client is going to have pre-medication. The client is going to be intubated. The client is going to be, ¿cómo se llama? Under anesthesia. Is going to be sleeping. Is not going to be aware. Is not going to have movement because it's going to be relaxed by medication. Yeah. So there is not going to be seizures. Okay, and it's like a surgery. And after that, the patient need to recover from the anesthesia. And you need to know that during the recovery of the anesthesia, the patient is going to experience a period that is variable of amnesia. So the patient need to be reoriented, need to be explained what have been done to them, etc. Okay, and that is important. The amnesia is the main side effect. But of course, people that have pacemakers, people that have cardiac dysrhythmia, people that have brain tumors, increasing intracranial pressure, etc., the people with fracture, etc., have contraindication of this therapy. Schizophrenia is the other psychosis that you need to know. And in schizophrenia, it's important that you discriminate what are positive symptoms and negative symptoms. They are not good or bad. They are all bad. Okay, they are all bad. But some symptoms are called positive because in this situation there is production, creation, you know, of something that is characteristic of the disease. While in the negative symptom there is loss of something that the client had before the disease. When the client acquires, gain, produces something uh, that didn't exist before, it's called positive symptoms. So when the client has a delusion, a crazy idea, when the client starts saying that is ¿cómo se llama? A native of the planet Mars, that is something that happened new in the evolution of the schizophrenia, has a crazy idea, or when the client starts thinking that the nurse or the physician wants to kill him or her with medication, with that are in reality poisons. Yeah, this is something positive because the client is creating, is producing, is generating something that didn't exist in the real world, didn't exist before. That's why it's called positive, because there is creation, addition, gain of symptoms. It's not good. It's not good to have delusion. Yeah, but those are examples. Okay. Uh, the delusion, the demo, is an abnormal thought. Is an abnormal thought. Is in the mind. And a very common delusion, crazy idea in schizophrenia is the paranoia. Paranoia is an unrealistic, it's not real, a, a threat idea, a threat, a fear. Understand? And the doctor want to poison me with this pill. And then you know how difficult it is to have a client taking the pills to improve the schizophrenia when they think that the pill is a poison. Makes sense? Uh, uh, Another example of delusion. The devil is forcing me to think on killing my child. Yeah? The devil is not talking, it's not a hallucination. But the devil is introducing in my brain, in my thoughts, in my thinking, an idea. It is called thought insertion, you know? Okay? Thought insertion. You are making me think about this. Okay, it is a thought insertion. Yeah, it is something that is in the mind. Okay, this is another example of delusion, of crazy idea. And I don't know if you know, there are cases of mothers, okay, also fathers. I don't know if you watched this movie called The Shine. It's wonderful food. Okay, Jack Nicholson. This is one of the best movies that you can watch. The Shine. Okay. In that case, he was a schizophrenic, and he was having those delusions. And then, okay. ¿Cómo se llama? Many years a woman that kills all her children. Kills all her children. How a mother can kill all her children? It's crazy, guys. It's an schizophrenia, you know? And this is the delusion that the children are, evil, and then that to save the mankind, okay, they need to kill the children. You don't understand how the mind of these clients is working never. Or look at this, how funny. An alien performed surgery and replaced all my blood with Kool-Aid without leaving a scar. What is this? A crazy idea. Okay, a crazy idea. That's it. It is a delusion. But sometimes the client is hearing or seeing something that doesn't exist, and the famous voices, okay, voices that are talking, okay, are talking, okay, and then those are called hallucination. You know, the perception of something that doesn't exist. It is also positive. Why? Because it's gaining, it's producing, it's generating, it's creating something that didn't exist or doesn't exist. I hear demons talking to me, okay? And there is not any sounds, any voice, you don't hear anything, okay? This is a hallucination. Or an illusion that I hear demons talking outside, okay? So what is the difference here? Outside are two nurses talking on the hall, and then the crazy person is hearing the voice of the two nurses, two real nurses talking in the hall. But then there is a misinterpretation of the voices of the two nurses talking in the hall. And the client saying, I hear demons talking outside. We assume that nurses are not demons, no? Nurses could be demonic, okay? But we are assuming that is not the correct interpretation, no? I hear demons talking outside. In this case, there is nobody talking. There is not any sound. Yeah. And then the client is hearing a voice talking, okay, to him or to her. You see the difference between hallucination and illusion in a very similar situation? Okay.
Yeah,
I assume that is easy to understand with this comparison. Okay.
yeah. Well, is allowed to ask the patient what the voice is saying to him.
I don't like this option. Why? Because it is allowed. There is no prohibition of that. But the way that you ask that need to be very careful, you know, because it's important for you to know what the client is thinking, and you can explore that. But the way that you make the question need to be very careful. So we are going to practice that. We are going to practice that very soon because of the upcoming slides. Okay, allow me to finish with the other classifications of positive symptoms to finish the concept of what is positive symptoms because are frequently tested in anchors if you can discriminate to tell apart what is a positive symptom, what is a negative symptom. Yeah. So understand that when you are producing this very creative, okay, manifestation of the psychosis, it's a creation, it's an addition, it's a gain, you know, and for that reasons are called positive. Yeah. The other positive symptoms are the language disturbances, and there are a lot of classical language disturbances in schizophrenia. Okay, probably let me start with the one that have been more frequently in English, echolalia. Mm,
Echo.
the neologism, here is neologism. Okay, I didn't find neologism. Okay, uh, maybe the flight of ideas. I personally had in my English clan association. I personally in my English had okay clan association. Okay, I had this in my English, but the one that I always I'm receiving that the students repeat me is the echolalia, the neologism, and of course flight of ideas, which is a very basic okay concept. Okay, what is clan association? Okay, it's not a common question, but I had this question in my English. Sometimes you see that the schizophrenic client is speaking like the people that make rap. So they speak rhyming, rhyme. You know what rhyme? When the sound of the word okay rhymes. Okay, I heard the bell, well, hell, then I fell. So notice L L L L. Understand? And this is the way that I had that. I have a run of words separated by commas, okay? But all the words that were not related at all, were not related at all, sounds similar. And then they give me four options. Suppose that was clan, ecolalia, copraxia, and flight of idea. And I needed to mark clan association. This is the term that they use when those clients start speaking rhyming. Okay, they find the way of rhyme. Okay, when they speak. Okay, this is the way. So you know what is rap, no? And rap we trying to make a rhyme, no? It's like rapping is rhyming. Okay, so this is clan association. Okay, so what is the onomatopoeia of a bell. Clang, 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 clang. Okay, so when you repeat something, clang, 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 the same sound, it is clang association. Echolalia. Echolalia, in a way, is an echo. You go to a very good resonance, or a very good acoustic theater, and then you have an echo. You say something, hi, 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 hi. This is an echo, no? Okay. Entonces, ecolalia is when the client repeats. Lalia is word, is language, yeah? Repeat what you said. You say hello, you say hello, good morning, and the patient say hello, good morning, hello, good morning, hello, good morning. Okay? What's your name? What's your name? What's your name? What's your name? I remember an English question. It was 8 a.m. in the scenario. The MD is walking through a room, a room, okay, the door of a room of a client with schizophrenia. And when the MD passes through the door, open door of the room, the MD hears the client, the male client saying, "Good morning, I'm Ruth, and I will your nurse today. Good morning, I'm Ruth, and I'll be your nurse today. Good morning, I'm Ruth, and I'll be your nurse today. Good morning, I am Ruth, and I'll be your nurse today." What is this? Echolalia. Because at 7 a.m., the upcoming nurse, the nurse that is receiving the shift, yes, need to make a round, pass through all the rooms, and present his or herself. "Good morning, I'm Ruth. I'll be your nurse today." The client heard that, and the client is 8 a.m. and it has been repeating since 7 a.m. when the nurse introduced herself, okay, and repeating that. This is more or less a question, an English question, in which the physician hears the client repeating that, and the physician knows that the client is repeating what the nurse has said when she enters to her shift, and the client is repeating that. Echolalia. Those are the way that can be tested. Have you noticed when it is explained, it sounds easy. Of course, they give you other three options that could be confusing. For example, delusion. You could think, oh, this is a male a schizophrenic client that is having the crazy idea that he is the nurse and he's going to be his own, okay, his own nurse today. An example, and I'm just talking that sometimes the questions are difficult because the distractors, I mean the other options that are not the right options, are confused. So I'm preparing you for how can happen in English to be aware. Neologism. I have a very fresh question, a very fresh question, but I don't remember now the neologism. Was so funny. So the students, pardon, the student, the client, the schizophrenic client, states, "I cannot find my Roccodexa. I cannot find my Roccodexa any place." Entonces, I cannot find my Roccodexa any place. Okay, my Roccodexa. I'm inventing in this moment this word. Okay, there was another word, the one that is in the test, but the same. It's a neologism. Neo is new. Logo is word or language. Yes. Okay. And then it is, I cannot find my Roccodexa. Okay. So what is having the client? Hallucination? No. What is having the client? ¿Cómo se llama? Delusion? No. It is a new word invented. Okay. Invented by the clients. Maybe the client has lost, I don't know, the pen or whatever, but they now is renaming, okay, the pen that it has lost, okay, as a Roccodexa. I cannot find my Roccodexa anywhere. Okay, what is that? Neologism. The best answer for that is neologism. Make sense? Okay, so those are the way that English make practical questions about your basic knowledge of the most common alterations uh, that you can see in schizophrenia. And for example, also they can say, cellular apply, which of the following manifestations are positive symptoms. And then they can start mentioning the stuff that have been mentioned. The other is the ecopraxia. Praxia is actions, okay, actions, yes, like walking, like combing, like the, scratching your nose, this is praxia. The movement that you do are defined as praxia. Okay, when you have apraxia or apraxia, okay, with an a before praxia, if you lose the coordination of the movement. For example, if you know the movement, the movement to brush your teeth. You learned the movement. You do that automatically. Yeah? And then some people have a stroke, and then they lose the learning of how to brush the teeth. Okay, this movement is lost, or how to fasten, a belt. Okay, so this is apraxia. Okay, when you lose this movement. Okay, echopraxia is when instead of word is movement. So you are, interviewing a schizophrenic client, and you have a notebook and a pen, and you are writing what the patient says, and then you see that the client, you know, make the mimic that he or she is also writing. So is imitating your movement. Yeah. Maybe I remember I have a psychiatric professor, very tall, and have very long hair, and who's to comb the hair very, very, high. No, it was very impressive. The psychiatric, the physical, the psychiatric. And I remember, in the mental health facility where I make my rotation many years ago, the last century, a client that wanted, when the psychiatric came to make rounds, the client wanted to walk after the doctor, imitating all the movement of the doctor. It was so funny, was really funny. I can see this image in my memory in this moment. It was really, really funny. Okay, so it's echopraxia. It's the imitation of movement. Flight of idea. I am superstar. Goulet a mangoulet. This is neologism. This is neologism. Goulet a mangoulet. Malungay. Where are you? I love beer. So it's jumping from one idea to the other, and introducing even neologism in the jumping of idea, in the flight of ideas. Okay. Tangentiality is wandering from one topic and never returning to it. I, I had this problem with my mother-in-law. When I asked her something, she started, explaining details and telling stories in the past, and at the end, she get lost. She's 91. She get lost in all the story and never return to the specific topic and asking her. Okay. Of course, it can be a manifestation of early manifestation of dementia, of the age dementia, but it's characteristic of her when I ask her something. Okay, so is wandering from one topic and never return. Wandering means that you start talking about something, and then just you move to something associated, and then you move to something associated to the associated, and then you move to the associated with the associated with the associated, and then you end lost. Okay, where are you from? I'm from England. In England, we have fish and chips. It's the fast food in England. Okay, fish have gills. Okay, Aquaman has gills. So what has to do Aquaman? Okay, Aquaman with where are you from? Okay, so it's an example of tangentiality. Word salad. When they mix words, but words that don't rhyme. Remember, if the words are rhyming, even if they are not associated, it's clan association. But if the words are, a run of words separated by comma, but they are not associated and they are not rhyming, it's word salad. Christmas, teeth, radiant brains, apple, death. Okay, and the neologism we explain that. What are negative symptoms? When you have something that you lose it. Sadly, the schizophrenia make people lose important aspect, the affect, the mood, love, hate, passion is lost. And then you notice that they don't express any emotion, no love, no hate, no passion, no anger, no sadness, nothing. And this is called flat affect. And is one of the most characteristic negative symptoms, loss of emotions, that happens in schizophrenia. Is the loss of what they had. Make sense? It's a negative symptom. Neglecting their physical needs of nutrition, hygiene, etc. So it's a very characteristic of schizophrenia that the clients stop, washing, stop shaving, stop combing. It's very characteristic. So it's a negative thing. I remember a questions in English that say, well, how you know that the antipsychotic medication or the Seroquel, for example, quetiapine, is working and the client is bathing 3 times a week? What's the right answer? So now the client's taking care of their hygiene, at least is bathing 3 times a week. Okay? Uh, Anhedonia, yeah, already mentioned. So each time you see words that frequently have a Latin root, that have the prefix, the letter A or AN, those are negative symptoms. So anhedonia is the loss of pleasures. Energia, they don't have energy. A volition, they don't have volition. They don't take decision. They lack of motivation. A logia, very poor speech. So is me. Is don't You don't find word to express your thoughts. Makes sense. Social withdrawal is characteristic of those clients and is part of the loss of, of virtues or capacities that they had before. And then they don't call the family, they don't visit the family, they don't care about the family, they don't interact with the friends, social withdrawal. So you notice those are losses, no gains, are losses. That's why I call negative symptoms. Okay, I hope that they help you. What to do in hallucinations, in active hallucination, when the patient is decompensated? First, safety, ensure safety. So anything that promotes safety is good. Okay, and it's okay to explore any situation that could be a threat to safety. Okay, do you feel in danger? Do you feel that you are going to harm somebody? Do you feel that, those are questions that explore anything about safety. Okay, are you considering doing something that could be harmful? Makes sense. So those questions are good, are therapeutic, are, for safety. And those questions are not reinforcing crazy ideas, are just exploration if there is something that could be, unsafe. Second, acknowledge feelings of fear, anger, etc., that the patient can experiencing during the hallucination. Guy, if you have a hallucination, you are hearing a voice, okay? You are hearing the voice of Jesus Christ, of Virgin Mary, that is telling you need to kill your mother because the mother is going to bring the devil to the world. You know, you are going to have conflict emotions and you are going to be very afraid or angry of whatever, of what the voice of Jesus or Virgin Mary or the devil or whatever is unrealistic talking to you, okay, is going to produce emotions. Or maybe the voice is going to say, you are miserable, you don't deserve to live, you are crap, you are, you are, you know, etc., insulting the client. It is going to produce emotion. So this emotion that the patient is experiencing when having this need to be acknowledged. Okay, are you afraid? Are you angry? Do you feel insulted? It sounds terrifying. It must be frightening for you. For example, no, uh, uh, you have a client that tells you, "I'm so afraid because I'm seeing lions and tigers uh, in my bed." Okay, what? what what you need to do with this client that is terrified because is really believing that is seeing a lion or a tiger in the bed. And of course, anybody of us, any one of us that see a tiger or lion in our bed is going to be terrified. Is going to be, very afraid. Obviously, yes. And okay, you need to say, I don't see anything. I don't see any lion here. I don't see any lion here, but it must be, I believe that you are seeing them, and I recognize that would be a very terrifying seeing a lion in the bed. So what you are doing, you are reorienting the client, telling the clients, I don't see the lion. I don't see the lion. What you're doing, reorientation to reality. Can a client schizophrenic or bipolar be reoriented? Yes. Clients with functional psychiatric diseases, psychosis, can be reoriented. It's very common, the question in English, of a schizophrenic client that is hearing voices. But the client has already evolved, improved with psychotherapy, reorientation, and treatment. And the client knows that those voices are not real. The client continues hearing the voice, but the client has improved, has evolved to the level of understanding, has been reoriented so efficiently that the client now knows that those voices are not real, are part of his or her disease. And the classical answer is how the clients, they say, I know they're not real, but they're continued bothering me. What I can do, nurse? Don't say. Very simple. Take, headphones and listen to music very loud. This is the answer in the question. This is an English question. It's an English question. So can those clients be reoriented? Yes. It's important to reorient the client, yes. But if the client tells you, okay, like in the school, um, the devil is insulting me, and you only say, what is the devil telling you? Now there are two people, the nurse and the client, that believe that the devil is speaking. So there's very a big difference when you have an option. When you say, I don't hear any voice, I reorient. But I recognize that for you is real. And it should be terrifying, should be very, 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 spooky, very, very horrible, having the devil talking to us, you know? So you are acknowledging that for the client is it real as part of of his or her disease, and you're acknowledging that the having the devil insulting us is something very horrible, you know. But you reorient. I don't hear any voice. It's different from the classical. What are the devil telling you? You are reinforcing the hallucination. You are not reorienting the clients. So expect in the NCLEX that the best option is when you at the same time explore, assess the hallucination, the content of the hallucination, you reorient the clients. And don't forget, the priority after safety is reorienting the client. And the safety is the safety of the client and other clients, not your safety. Okay, it's not a classical. Ask the client what is the voice are telling. No, just in case the voice is telling, kill the nurse, kill the nurse. It's just to protect yourself. Yeah, remember that the English is for the clients, not for the nurse. Okay, so it's important that you take care in the way that you are exploring. Okay, so always provide reorientation. I don't hear any voice, but I like to know what you are feeling. I don't see any blood coming out from the faucet. Nurse, there is blood. I open the faucet and there is blood coming out. I don't see blood. I see water. But it should be okay. Very scaring. Okay, seeing blood coming out from the faucet. Okay, Don't reinforce the hallucination. What is the demon saying simply? No. But accept that for the client, it is real. They are hearing the voice. The voice is real for the client. And you acknowledge that to the clients. Don't challenge, don't challenge the illogic, okay, of the hallucination. Demon don't exist. Okay. You don't need to argue because for the clients it's real. Okay. Don't argue with the clients about okay the logic of that. Demons are not allowed in the hospital. Only me. Okay, so this kind of answer, of course, are not correct. And the distraction techniques are okay. Okay, try to listen to music, headphones, watching TV, humming, playing. Those are interventions that are adequate dealing with the hallucination. In delusion, the main problem is the paranoia when the client doesn't want to receive the medication or doesn't want worse, doesn't want to receive food because it's thinking that the food is poison. So then the question is going to be practical. For example, I remember a question in Nclex that the client had paranoia, delusion, paranoid illusions with the portion food. And then the solution was asking the kitchen to send the food wrapped, so all the food came wrapped. So there is no the clients believe there is no opportunity of poisoning the food by the nurse. In the end, is a solution. Examples. Okay. Um, there is a form of schizophrenia called catatonic schizophrenia. There are many types of schizophrenia, but we are not psychiatrists. Don't waste time making a specialty of psych mental health to go to the English. Okay, includes basically management, includes basically safety, is basically infection control, is basically basic nursing fundamentals, etc., etc. And a little mental health, a little OB, a little pediatrics, and a lot of adult med search. Okay, but it's good to know this because you are going to have questions, a percentage of questions about mental health. Okay, but notice how extensive is the topic because I showed you in the last class the English test plan to know what is considered mental health in nursing. You will surprise what is considered pharmacology if you go to your English text plan. What is considered pharmacology in English, and you will be changing the way that you study, and you will be a lot more confident with yourself if you know what is pharmacology for English. Okay, so that's why it's important to read to explore the English test plan that is available for you in their page. Okay, there is a form of schizophrenia that is different from this schizophrenia that have been mentioned before, that is most commonly the paranoid schizophrenia. Okay, there is the catatonic schizophrenia. The importance of the catatonic schizophrenia, there are periods, not all time, periods in which the client is not moving, is frozen. Okay, and when the client is catatonic, is not moving, it's frozen, is not making the movement. Don't go to the bathroom. If they are, is standing in the in the patio of the facility, is not moving from there, even it's raining, even there is a lot of sunlight. Okay, so this is catatonic. Okay, and what is the basic in a client that is not moving, is not going to the bathroom, is not eating? The basic Maslow basic needs again. So the questions are so easy, are so basic. What is the basic there? Is the basic needs: food, water, hygiene, etc. Look at these questions. This is of the um what English publishes, okay, of possible questions, okay, of the preview of the test that they publish in this same page that I mentioned to you before, where you can find the encrypted plans. A male client diagnosed with paranoid schizophrenia is committed to hospitalization. You need to know the word committed. You call that Baker Act. In the English, Baker Act doesn't exist because Baker Act is only in Florida, and English is not a Florida test. It's a national test. Okay, it's a federal test. Is committed. Commitment is the word for when the client is hospitalized against his or her will. It's like going to jail, but instead of going to jail, you go to the hospital because you are cuckoo and you are a threat to yourself, like a suicidal client, or a threat to others, a homicidal crimes. And is committed to hospitalization by the police when found hallucinating, armed with a rifle, and threatening to kill everybody. So it's a homicidal reason. Since admitted to the client has been physically aggressive with the nurse and other clients. This is a violent client. Which right keeps the client when hospitalized as involuntary commitment, which is the term they use for this Baker Act. Right to sign consent. It is correct. Right to refuse treatment, including psychiatric medication. This is correct. Right to be restrained when needed in the least restrictive way if needed. It is correct. If there is need to restrain the client, should be restrained first in the least restrictive, efficient way. Right to abandon the facility when feeling better? No, the patient cannot leave the facility when they want. Right to file a habeas corpus petition to a court? Yes. What is this? When you are in jail, you can request to the court to be left free. It's called habeas corpus. Okay. If you can request the court to leave it, and maybe they allow you to go live, okay, if you pay a certain amount of money, etc. Okay, it is correct. And right to vote, yes, it is good. Psychiatric patients have right to vote. Okay, and this is an example of questions of the Nclex preview that published of Nclex. So generally, the concepts, especially people coming from, in my case, from other countries, that if the client is a risk, you can give the medication against his will. That no, you cannot do that. The law says that the patient has a right to refuse treatment. Okay, and please, in Nclex, go by the law. Don't start inventing going against the law. Delirium versus dementia is an important difference that is frequent, super frequent in English. I heard a lot of people had question about this, very basic question, and I remember having this question in my LPN English. Delirium is reversible. Dementia is irreversible. Delirium is relatively acute, occurs in a short period of time. Dementia is something that exists and progresses along years, decades. And it's the big difference between delirium and dementia. The client with delirium and the client with dementia can be either one cuckoo, can be, out of his or her mind. But what there is difference. Delirium generally has a specific cause. For example, if you are very drunk, you are under the influence of an overdose of alcohol, you can be having a delirium. If you are consuming certain drugs that alter your mind, like cocaine, amphetamines, hallucinogen drugs, you can have a delirium and can look like a dementia, but it's not. It's something acute. It happens immediately after you consume the drugs. If you are having hypoglycemia, you can behave aggressively. You can start beating people during the hypoglycemia. It happens a lot to me in my experience as a nurse with hypoglycemic clients become very violent. And then after that, they are so, they experience shame and that, a lot of regrets, and they are, asking for your forgiveness, okay? uh, uh, Clients that have, especially old clients, an infection can develop, can become cuckoo, crazy, okay? And it is an example of delirium. It's a classical question that a old person, old client with a urinary infection can present with alteration of the head, alteration, confusion, disorientation, can be agitation, can be lethargy, etc. You know? Clients that have hyponatremia, low sodium, can present with delirium. Clients that are, having low level of oxygen, hypoxia, can become very agitated, confused, disoriented, wandering, okay, etc., etc. So there is a specific etiology. And because there is have a specific etiology, correcting this problem, then the delirium can revert and can decline, return to normality. These abnormalities generally are acute, occurs in hours, days, very short period of time. Dementia is different. Dementia is different. Dementia is slowly installing along years. It's chronic and progressive, and is not reversible. Each day is going to be worse and worse and worse and worse. The most common is Alzheimer's dementia, but there are many other type of dementia, frontotemporal, vascular, etc., etc. In dementia, what is first impaired is the memory. Yeah, the memory. Then the logic, the reasoning, the cognition, the decision taking. Yes, but the client is totally awake, is totally conscious. No, it's not sleepy, it's not sedated. Of course, can be sedated by medication that can be given to those clients, but not by the disease. But in delirium, the client is sleepy. If the client has decreased level of consciousness, it's not Glasgow 15. It's going to have some level of alter of the level of consciousness. Okay? The treatment of delirium, the treatment of the underlying cause, eliminating the underlying cause. The treatment of dementia is mainly hope. Hope never should be lost. But sadly, the treatment is not very effective. The treatment intend to slow down the progression of the dementia, and maybe it's possible. So those cholinergic medications like Donepezil, rivastigmine, etc., could maybe, who knows, slow the progression of the disease, but is irreversible. There is not improvement. And of course, keeping the mind active. How you can keep the mind of chronic dementia active? Interacting with other people, okay? Making the clients, practice the memory. And there is something called reminiscence, in which you remember nice stuff, nice memories that brings a lot of pleasure. And then it's reminiscence, okay, remembering, nice pictures, nice movies, nice music, interaction with other people, etc. Those are, okay, the stuff that can slow down the progression of the dementia. Sometimes depression, especially in old people, can mimic dementia. And then when the clients receive antidepressants, the dementia disappears. Sometimes hypothyroidism can mimic dementia. And then the treatment of the same levothyroxine and the dementia disappears. So understand that there are sometimes situations. The one that has been in Nclex tested is that if you know that depression in old people can mimic, can imitate dementia, even with alteration of the memory and decision taking. And there's some Down syndrome. Some Down syndrome is something that happens with that. We don't know really why. When the client is tired in the afternoon, and the client is seeing the sunset, okay, and then you know the shadows, and you are tired in the afternoon because you are being, dealing with yourself all the day, and then the clients start misbehaving in the afternoon and the night. What we can do: illumination, light is good to reorient client. Good. Light is good. Light is not good to mania. Yeah. Light is not good to mania or somebody that is agitated. Okay. That is violent. Light is stimulant. But a client that is having that light is having, disorientation, confusion, even hallucination. Illumination will reorient the client. Uh, of course, frequent reorientation, company, reminiscence, okay, is going to help the client. Alzheimer's disease generally is classified mild, moderate, and severe. Moderate is the longest state, and 99.99% of the question in NCLEX say that the client is in the moderate stage of Alzheimer's. Mild Alzheimer's tends to be asymptomatic. The patient is functioning normally. And the research says that can last decades. So if I'm starting Alzheimer's, okay, maybe I've been for the last 10 years, growing the alterations in my brains that will bring the Alzheimer's in the future. So it's a very, very, oligosymptomatic or asymptomatic period. And then there is mainly alteration of the recent memory. So it's difficult to diagnose. There is no important questions about this. Moderate is when the Alzheimer presents with all the characteristics that makes difficult to manage the Alzheimer's. Because the severe Alzheimer's is when the client already is immobile, is not moving, is in a wheelchair, is in the jetty chair, is not eating, not swallowing, so has a peg tube, is not speaking, is not verbal, only screams, you know? So it's easier to manage because it's total care. It's true, it's total care, but it's not wandering. It's not aggressive. It's not, it's those severe cases that usually you see in the long-term care facilities in the nursing homes. At least when I was at LPN at CNA, I work a lot with this kind of client. The moderate is the difficult to deal. Why? Because they are still having a personality. They are still walking. They are still, strong and it can last many many years and is uh is extenuating dealing with moderate Alzheimer for the family, for the kings of the client. um it's important that in Alzheimer's you need to reorient is decent, reorient is correct, but reorientation is different than in client with schizophrenia, mania, bipolar, or other functional diseases. You don't expect that the client will remember, will uh, 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 just keep the reorientation. So don't expect learning of the reorientation will be lost, will be forgotten immediately. Okay? Don't expect memorization. Don't expect reality orientation. For that reason, the practical approach could be a little different. Let me explain. I have a client. We today is November the 30th, no? Yeah. Uh, I have a client in a nursing home, a facility with moderate Alzheimer, who wakes up today thinking that today was January the 1st and woke up wishing Happy New Year to everybody. So was very excited, okay, when woke up in the morning in the dining room where everybody was having breakfast and was wishing Happy New Year to everybody. Happy New Year, Happy New Year, Happy New Year to everybody, hugging people, etc. And some people that recognized that it was inadequate, other clients and etc., or were laughing, making fun of the client, viejo loco, uh, or were upset with this reaction. So this was the scenario. And the question said, what is the best to do in this case? Option A, I remember, was reorienting the client, showing the newspaper. The newspaper has today's date, and it is a reorientation to make the clients aware that all these alteration that was producing, reaching Happy New Year's was a nonsense. Second was ¿cómo se llama? Uh, Following the guide of the client. This is wishing Happy New Year to the client. So the client is asking you, Happy New Year, say Happy New Year, and giving a hug, and you return the hug. Third was giving a sedative. This is always wrong. And fourth is taking the clients apart and offering a nice food, okay? Assuming the client was hungry, was waking up, and offering a nice food. Uh, of course, you were between the first, reorienting the client with the newspaper, and the last, okay? Deviating the client from the dysfunctional behavior was taking. If you offer the newspaper, probably the clients will have an emotional reaction. So could be shame. So the client will be very frustrated, ashamed, because he's realizing, no, I'm crazy. My mind is killing me. Okay. So I'm very sad and very ashamed because my behavior was so inappropriate. How I could be thinking today was January the 1st, if today is November. How I can be so disoriented, how bad I am. Oh my goodness, I'm so sad. Or by the contrary, very upset. This is the way that I react when I realize that I'm wrong and become very upset. Okay, upset with myself, but somebody need to pay. Okay, I need to project. Okay, I need to project my stuff. No, it's because you are making me crazy. You are driving me mad because you are disorienting me. You are the fault is yours. It's because the medication is not good. I'm projecting in somebody my anger. So it's not going to be productive. It's not going to be helpful. And do you think that the clients will remember in the afternoon that today is November the 30th?
No.
No. So it's not realistic. If the client were a schizophrenic or a maniac, yes, because they will remember, they will learn. But in this client, no. And this is something that you need to learn, and it's going to facilitate you a lot how to answer question with Alzheimer's clients. So it's better to find win-win solutions in which the client is deviated, distracted from the dysfunctional behavior, okay, and is attracted by a reward, something more specific, okay. So basic reorientation, don't expect learning, memorization, reality orientation. Instead redirect the client to activity that they can achieve. Provide a calendar and a clock is not harming the client. Okay, I did that with my mother-in-law, but she's still asking me every day what day is today. Okay, or what time is it? She had the clock, she had the calendar, but she's not looking to the calendar, the clock. No matter that I'm been reminding her all the time to check her calendar and the clock. But we need to do that. I had to do that. Okay, it's not working, it's okay, but I had to do that. Having the picture of her, of the grandchildren, etc., is good. Use distraction, as I said before, when they become agitated. Use the line, aha, this is frequent. Sometimes, okay, the client with Alzheimer's becomes very upset and very aggressive, okay? When you are going, for example, giving a medication. What you do, stop there. Don't bother the clients anymore. Leave. Don't argue. Leave. And allow the time to pass. Time can be 15 minutes, and then return again and attempt again doing what you want to do. For example, give the medication. You will surprise how soon the client forgets, okay, uh, the anger or the whatever is causing the inadequate reaction. So I'm using the client's forgetfulness in my favor. Okay, I come back later. And this is a classical question in English and very easy question. Please don't fail this question. Always provide simple instruction. Don't ask what you want to eat. Ask, do you want chicken or pasta? Do you want beef or fish? Give simple decisions. We usually avoid close-ended questions, okay? In the other kind of people. But in this kind of piping, it's good to have close-ended questions. Do you want to eat? Yes or not? Okay. Um, prevent the unsafe wandering. Okay, locks in the door, alarms. Uh, this is commonly in English. What was wrong with the family member in his instruction? Don't take your father to the park and leave the father walk because can be lost. Don't leave your father alone in the garden to take sunlight because can become lost. Know that they tend to escape, to elope, to wander, and they get lost. Encourage reminiscence. Reminiscing is good for old people. And you know how you do that? Okay, you make groups of old people of the same age, the same characteristic to talk among them. You sit and you browse pictures and you talk about the past, movies that reminds the past, etc. Okay. The problem of the insomnia at night. Uh, Promote daytime exercise before noon. Okay, before noon to promote sleep at night and avoid naps. Okay, and don't forget what is respite care for the caregivers. The caregivers are more extenuated and more affected than on Alzheimer clients. They need some relief. And what is a respite care? Well, the Medicare and also hospice includes uh, a HHA, a home health aide that can go home 1 day or 2 days, 3 days, depends on the insurance, to take care of the client while the caregiver is having some time free. Uh, or they are day cares, okay, for old people. And this is example respite care for caregivers. Drugs using Alzheimer, remember those names. Donepezil, rivastigmine, galantamine, and memantine. Why? Because all the question that I see in anchors is the client is taking rivastigmine, okay? Rivastigmine, okay? What disease has the client? Has Parkinson's, has, I don't know, myasthenia gravis, has whatever, has Alzheimer. And the answer is has Alzheimer. So what is the question that I think about this medication? Basically, for what are used those medications? You know, those are Alzheimer's medication. And those are cholinergic medication. Increase acetylcholine. Acetylcholine is the parasympathetic nervous system neurotransmitter. And the parasympathetic makes the intestine move. So, which side effect could have those medications? Diarrhea is the most important. Diarrhea. So, stimulation of the parasympathetic nervous system. What happens in the heart if you have a stimulation of the parasympathetic nervous system? Bradycardia. So could be contraindicated in a client with AV block with bradycardia. Hmm? Don't confuse cholinergic with anticholinergic. Atropine is an anticholinergic that produces tachycardia. Yeah, produces tachycardia and produces constipation because it's anticholinergic. Those medications are cholinergic, stimulate acetylcholine, so stimulate the parasympathetic nervous system. The most important of pharmacology of medication, enough to deal with pharmacology question with that. Okay, let me read some stuff that can be found in the National Institute of Health.gov in the branch of this governmental okay institution that is the National Institute.
Nothing. Give it to me.
I I can't hear you. I can't hear you, Professor.
Professor, we lost you.
Somebody mute me. Okay? You have the power, the way that have been created this link of muting me. Okay, because I'm not as a presenter. So somebody mute me. Now you can hear me, yes?
Yes, we can.
Okay, so somebody mute me.
Yes.
Okay, take care. You can mute me. Don't mute me. Okay, mute yourself, but not me. Okay. So here is read. Okay, smoke and carbon monoxide detection in kitchen of the bedroom is good. It can be a select or apply question or a clinical scenario question. Emergency phone numbers near all the phones is good. Safety knobs on the stove. Okay, important. Child-proof plugs for unused electrical outlets. You know what is that? Plugs that you put in the outlets, electrical outlets to prevent accident. Child-proof latches on cabinet to lock medicines, alcohol, cleaning product, guns, knife, etc. So look how we treat patients or people with Alzheimer's similar to children. Reduce furniture, leave the way free, and eliminate clutter. Classical. Put carpet on the stairs. Look at this. Carpet on the stairs, wall-to-wall carpets, okay, on the stairs makes it less slippery, and in case of a fall, is more cushion, is less trauma. So it's recommended. It's written there. Or mark the edges of the steps with bright colored tape. Remove a mold throw rocks. Use rocks with non-skid backing instead. So if they are going to use rocks, need to be with a Velcro system that make it attach to the floor, or you know, or nail to the floor, etc. Make sure cords to electrical outlets are out of the way. There is no electrical cords in the middle. Uh, or tacked to baseboard behind furniture. uh, Clean up spills right away. Non-skid shoes or socks, those that are giving in the hospital. Make floors and walls different brilliant colors, no pastel, no dark colors. Look at this. Somebody had been having recently question like this cellular apply, and they had this limit the size and number of mirrors. Understand that you have mirrors. It can be confusing. Okay, can be confusing. Have you ever seen an animal confused with a mirror? You know, it can happen with all people also. Signs or simple pictures to label the bathroom, bedroom, and kitchen. So put a picture in the door of the bathroom and the bedroom to make it easier to identify and discriminate among many doors which one is the one that is of the interest for the old person. Take care with pets and falls. Pets can produce a lot of falls in old people, especially cats. Reset your water heater to 120. We have been talking about this. It's so common, this topic in English. Install grab bars and shower chairs in the bathroom. Is good. Prevent wander. Safety locks on doors and identification tags in the clients. Okay, so this is a list that can be found, as I said, okay, in home safety checklist of Alzheimer's disease in the National Institute of Aging, which is a branch of the National Institute of Health.gov. The same that I've been recommending you, the CDC, for questions about infection control, disease management, etc. And this kind of question is so frequent in the dealing with old people. Okay, I recommend this source of information for that. Look at this question. You find a client with Alzheimer's dressed at midnight. You are in a nursing home, for example, and then you find a client dressed up, okay, dressed up at midnight when she'll be sleeping. When the nurse tells her, because it's a her, Mrs. Laurent, why are you dressed up? The client answered, I'm waiting for my husband to pick me up to have dinner outside. Her husband has been dead for many years. Which is the best nurse answer? A. Your husband died 10 years ago. So reorientation to reality. What is the possibility of reorientation of this client with this statement? It's not true. You are lying. How can be? I'm pretty sure he's alive. Or I didn't know when he died. Nobody told me. Oh my goodness, I'm so sad. Yes. Or liar, liar. Okay, whatever. So, do you think that the reaction that you're going to create at midnight, okay, reorienting this client with Alzheimer's to reality, telling again something that probably she had but forgot, that her husband died, is not being productive. It's not logical. In another person, a person with Alzheimer's, it could be the correct veracity, but not in this client with Alzheimer's. That sound, yes? That sounds interesting to do. It's not addressing anything. It is even mocking the client. I see you're having a sundown episode. My goodness, it's despising the feelings of this woman. Why we don't sit and take a snack together? Obviously, this client is totally disoriented. Okay, but what you can do is to make the client forget this dysfunctional idea of having her husband coming to pick her up to have a dinner outside. And obviously, the client is hungry because he's expecting to have a food, and obviously, it's a good idea to deviate her dysfunctional behavior to something more functional as having a snack. Okay, guys, the time brought us to here to us today. So, any question, any doubt? Are you good?
Yes,
Professor,
thank you,
that answer
Professor.
was B. The answer was the last one?
What do you think?
Yes.
Yes. Yes, the last one.
What do you think
Thank
about?
you.
Okay, okay. It's important what you think because it is a proof that you understood. Okay, what is uh, what is said there. Okay, so take the client to have a snack and don't attempt reorienting the client to the reality, which is that her is a widow. Okay, because it's not going to be remembered. It's not going to be okay accepted. Okay. Okay, guys. See you next time. Bye bye.
Thank you, Professor.
Thank you,
Thank you.
Professor. Thank you.